Welcome to the 8 Minute Rule podcast, where actual physical therapists share clinical pearls designed to create conversation around what's getting results in the clinic. No fluff, no Medicare stopwatch, only quality content. Welcome back to the 8 Minute Rule. I got Mark and myself here. Idea that we want to go over today and walk through essentially how to progress with pain, talking mostly to clinical individuals here. And so we want to get kind of an overarching big picture look of in the clinic, we obviously have a lot of patients that are in pain and how we're utilizing that and working with that. So starting off here, Mark, big picture question. You got a new grad clinician coming in, mentored plenty. What's it look like when you're trying to navigate their mindset around how to progress patients that are in pain?
So, first and foremost, they don't need to be afraid of pain necessarily. And as a provider, you don't need to. I think it's a good thing to respect and use as a guide to how you're going to navigate working with this patient. But as we all know, some conditions are going to require a little bit of discomfort slash pain to get better. Um, and then there's the whole other side of things where, like, if someone's been in pain for 10 years and you have them do something that causes them a little bit of pain, it's like, okay, like, you were going to be in pain regardless of whether you came to me or not. So if I think that this is something that's going to ultimately get this patient better over time, as long as they're not keeled over and like out of commission for a week as a result of it, like, I'm okay with working into some of that pain. And so I think for a new grad, pain is normal. It's a normal experience that we have in life, and it can help us understand our environment and navigate situations. But take it for just that to start with, and then have a conversation with the patient about what's going on and everything, and then use your clinical judgment to say, hey, this is okay. Let's work into it, or hey, let's pump the brakes. Let's modify.
Yeah, I think those are all great points. I think about it. It goes back to a lot of the basics, which I know you and Drew have talked about countless times around, knowing the irritability. Like when you're in that initial eval, you're really trying to get a gauge early on. All right, is this somebody that's in chronic pain? Is it an acute flare up? Whatever, have acute on chronic. But still, do I know if we create pain right now, am I going to get a pretty good read on it and it's going to calm back down so I can keep working through my evaluation? Or is it going to flare you up and you're going to be miserable for a couple of days and you're never going to come see me because you're going to be hurting for multiple days? And so I think being able to pick up that individual of what's their tolerance from irritability standpoint is foundational to that. And I know you spend a ton of time on that with your new grads, and I do as well, just because of how important that is to guiding your clinical decision making. One of the things you'd brought up was obviously there's certain tissues that we need to create a pain response because we're really looking at tissue remodeling. We know the literature supports that. And so for you, what does that conversation look like now directly towards the patient when you're having a communication around, hey, we've got to create some pain here in order to be able to get to meeting your goals?
Yeah, so I use a Goldilocks analogy, and for some of the younger folks, I don't know that they get that as much anymore, but it's kind of the too much, too little, and just right. So usually for the too much, I'm saying, hey, 2 points on the NPRS, I'm okay with that. Anything more than that, we should probably talk about, if we need to modify things or not. And then on the flip side, too little is like, hey, if you leave and you're not sore, you don't feel anything with these exercises in your painful area, then we probably haven't done enough. And then, so I go with that Goldilocks zone is like the sweet spot where, like, hey, sore is safe. And I expect you to feel sore, one. And I also expect you to feel a little bit of the kind of discomfort that's bringing you in a mild way. Again, remember, 2 points. And that's going to help us know that we're in the right, threshold where we're going to be making positive changes to your symptoms over time. If we're on the either end of the spectrum there, it's probably not going to be as effective as it could be.
Yeah, I love it. I'm old school as well. The Goldilocks analogy I kind of go with, and I'm using my hands here. Like, you do nothing, you're going to stay here. You get too much, yeah, you can hit this spot and back down, but obviously we want to hit the sweet spot in order to get you better, because doing nothing is just not going to make you better. And I mean, yeah, it's amazing how it seems like that resonates as much with anybody, because they've been sitting there trying to figure out, gosh, when I'm feeling good, I go do X, Y, and Z, and now I'm miserable for a while, and then I do nothing and it feels better, but it doesn't get better, right? And so I think most people have good awareness of that when you just explain it in that manner. Then obviously the key is how do we set you up for success and really get you in a position where you do load at that right tolerance, because you try and teach them loading and they go miserable and they're just going to go right back where they came from, not be able to load that well. So I love that. Other side of the coin, we've got certain, probably more patient populations. I mean, you could say tissues as well. When we're looking more in the chronic situation here, not all of them the same, but there are certain situations where it's unacceptable to produce a certain amount of pain. What is that conversation for you like in the clinic?
Well, I will say, kind of caveat to not answer your question is, for some of the folks with really chronic persistent pain, I don't talk to pain about pain with them at all, like pain levels. I don't get in PRS with them. I shift the focus entirely away from their pain to function. And so that's kind of a subcategory, but I felt like it was important to say. For the folks that like I'm actually concerned about the pain, where it's like, hey, I don't want you to have pain with this exercise. You can think of, we'll just use like a impingement thing. It's like, okay, if you go to the point where you get to impinging on a joint, whether it be hip or shoulder or whatever, like, are you causing more damage? Probably not. Like, it's probably not going to feel great, but I also don't necessarily want to replicate the mechanism of injury that you're coming to see me for, relatively especially. So I may modify an exercise to, work around that, or, maybe that's when I come in with my manual therapy and say, hey, let me try some of this manual, see if we can get you moving a little bit better, decrease the sensitivity of some of these tissues, and then go into this exercise. But that would be the case where I would have a conversation with the patient like, hey, I'm not afraid of this and you shouldn't be afraid of it either, but I do want to modify it just to make it more comfortable, because it's probably unnecessary to have you in pain while doing this exercise.
I love it. I could not have said that better. I think it all comes down to fear in this situation, and it's, one, how many times have we heard they're like, oh, I just didn't do anything for the last 3 months because I didn't want to hurt it. Right. At some point in that first month, you should have realized, hey, this isn't working. Like something's not working here. But I think the goal is just breaking down that fear response. Like, hey, no, you're not going to hurt it, and you are making it worse by not doing. So, and yeah, you could make it worse by doing too much, but again, you're seeing that you're not getting there at what you're doing, and so I think I love the idea of trying to decrease the fear response. And there's two categories that pop up in my head when I think through this, and one is your typical chronic pain patient that you're thinking a little bit older adult, kind of middle-aged old or whatever have you, some comorbidities, a lot of other things going on, and they're coming in with chronic pain, and you're just looking at changing their lifestyle. Literally, you give this person a walking program, looking at sleep, and maybe a little bit of change on diet, and that's the biggest thing you want to do in day one. But I'm sure you've seen it plenty as well too. But there's a growing population of teenage athletes out there that are coming in that have got chronic pain because they had an injury, rest of the day, were shocked that it didn't get better, and kind of kept playing their sport, and kind of had this over and over again. I had two phone calls from friends on their kids about this just in this past week. And they're all situations that I believe, I mean, probably should have taken a huge chunk of time off 6 months ago, but their nervous system has kind of adapted to being in pain there. And so I think, with all the populations, not to break it down and make it simple, but you're trying to reduce fear. And for some people, that's needing to load more. Some people, it's needing to load less, but you're trying to be able to just take the fear out of it in terms of movement, and create that as well. So kudos, love the way you approached it. I know you're doing some awesome things up there with that as well. But till next time.